A very good morning to all of you all. The Bombay Orthotic Society has been at the forefront of academic education for the past 53 years. With the evolution of technology, there has been a paradigm shift in the methodology of teaching and learning. We at the Bombay Orthotic Society believe that e-teaching and e-learning is the way forward. Hence, we are proud to announce the setting up of an orthopedic education e-portal on our very own YouTube channel. With our commitment to excellence in academics and our theme of winning decisions, getting it right the first time, we are happy to present to you a series of webinars by surgeons who are masters of their craft. Today's webinar, titled Winning Decisions in Benign Bone Tumors, will be presented by Professor Ajay Puri. Professor Ajay Puri is the head of Department of Surgery at the Tata Memorial Hospital and Homi Bhabha National Center. He is the head of Tissue Bank, Tata Memorial Hospital, the professor of Material Sciences and Engineering, the University of North Texas. He's a visiting professor at MGR University, Tamil Nadu, a visiting SICOT scholar professor. He is an examiner for MCH, PhD, and a member of various peer review committees. He is on the editorial board of almost 8 internationally acclaimed journals. He is professionally affiliated to multiple associations, national and international, and has served as the past president of the Asia Pacific Musculoskeletal Association and the founder president of the Indian Musculoskeletal and Tumor Society. He has various awards, publications, fellowships, national and international, and is an acclaimed speaker and a very well celebrated academician. So without further delay, may I now welcome Professor Dr. Ajay Puri and request him to present this webinar on winning decisions in benign bone tumors. Welcome, sir.
Thank you, Swapnil. Hello, everybody. And Swapnil, thank you for that generous introduction. And I must commend you and the Bombay Orthopedic Society for this initiative, because I think this is a good opportunity for us to be able to disseminate knowledge and help colleagues who would like to, as you say, get to the winning ways in various orthopedic procedures. So today I'm going to be speaking to you on benign bone tumors. And I think in bone tumors, benign bone tumors is quite important for the general orthopedic surgeon, because this is what you are most likely to tackle in your daily practice, rather than the malignant ones, which hopefully you should be referring to specialist centers. Now, benign bone tumors are a wide spectrum of diseases. From the simple unicameral bone cyst seen on the left of this slide to the aggressive giant cell tumor seen on the right, they require different ways in which you can manage them. Benign tumors are generally slow growing and rarely metastasize, where some, like giant cell tumor, are biologically more aggressive locally and may even occasionally metastasize. So therefore, to get it right in these lesions, which run a wide spectrum of presentation, you need to give a lot of thought as to how you should be treating them. For example, this unicameral bone cyst with a fracture, if treated conservatively alone, tends to heal. And you can see over a period of years how this has resolved without resorting to any operative treatment. Lesions like an aneurysmal bone cyst, which earlier were treated with invasive surgery and curettage, are now quite easily managed with just a sclerosant injection. Polidocanol is a sclerosant which acts by direct damage to the endothelial lining, triggering the coagulation cascade with thrombotic occlusion of the blood vessels in these lesions. This induces sclerosis of the aneurysmal bone cyst's vascular network and thereby achieving local control of the lesion. So a large majority of these lesions are now handled with just sclerosant injections rather than the earlier curettage and bone grafting, which was considered the gold standard. Osteoid osteomas also, which were treated with surgery earlier, now have the minimally invasive option of being treated by radiofrequency ablation that gives more consistent results with less morbidity, and that's how most of them are treated now. But it is these lesions, the so-called aggressive benign lesions, that need a lot of thought when you sort of decide how to treat them. And the first question that is often asked is it mandatory to biopsy these so-called benign lesions? I think the answer is an unequivocal yes. All benign aggressive tumors must definitely be biopsied before you embark on any definitive treatment. Take this case in point. A lytic lesion at the proximal end of the femur looks like a giant cell tumor. The unwary orthopedic surgeon possibly thought it was a giant cell tumor, went ahead, did a curettage and fixation, and was rather unpleasantly surprised when the final report came out to be an osteogenic sarcoma. This patient then, with a scar like that, contamination all around, landed up with a surgery like this, something that was eminently avoidable had a biopsy been done earlier and the diagnosis confirmed. Sometimes benign lytic lesions can be deceptive. This is a sacral lesion. A biopsy called it a giant cell containing lesion. The pathologist was not incorrect in calling it that. We went ahead and did a resection. And when the final specimen was seen, it actually turned out to be a brown tumor of the parathyroid. And then when we looked back at the reports, we realized that the alkaline phosphatase was high, which had possibly been missed. Patient was sent to the head and neck surgeons and the parathyroid adenoma removed. We were fortunate that the patient didn't land up with any neurological deficit, but this was something that could have been avoided because lesions due to hyperparathyroidism, if the parathyroid adenoma is treated, will resolve on their own and do not require surgery. So when you see any lytic lesion, a serum calcium phosphorus and a serum alkaline phosphatase is mandatory so that you don't miss lesions like this and do unnecessary surgery. But in aggressive benign bone tumors like giant cell tumors and some chondroblastomas, the general consensus is that because they are benign in nature, you would prefer a surgery that is more function preserving, that is intralesional curettage, rather than the more morbid resections. And to get it right, you need to ask the right questions. So when you see a lesion like this, the first question that you need to ask is there adequate cortical bone after intralesional curettage left behind to maintain or restore bone stability? If the answer is yes, then you proceed with what is known as an extended intralesional excision. That means a large enough window to visualize the entire lesion, an aggressive curettage to take out disease, use of a high-speed burr and pulsatile lavage to remove any microscopic tumor, and some surgeons may use adjuvants like alcohol or phenol, but it's not really been conclusively shown that these adjuvants can actually help reduce the rate of recurrence. Maybe it's the better technique and tools of today's era that have reduced recurrence rather than adjuvants. And if you look at literature, that is what most articles would conclude, that it is the importance of your curettage, the adequacy of your curettage that is critical rather than the adjuvants. And a poor curettage cannot be bailed out by the use of adjuvants. Therefore, adjuvants are not mandatory. We at the Tata Memorial Hospital don't use them. The key to trying to reduce your recurrence rates is doing an adequate curettage. Once you've done a curettage, you obviously have a hole left there. The next question is, do you fill that hole or not? And if you fill it, with what do you fill it? You have a variety of options available. You have autografts, allografts, bone cement, bone substitutes. How do you decide? So again, you need to ask the right questions. What is the amount of bone that is involved? What is the amount of bone that is left behind? If at the end of your curettage, more than 2/3 of the cortical circumference of the bone is intact and you have more than 5 millimeters of subchondral bone, then you really don't need to fill in anything. You can leave the cavity as it is with protected gradual mobilization, and the cavity tends to fill up on its own. The hematoma that forms changes into fibrous tissue and subsequently later can morphose into bone, and you don't need to fill these up. If these criteria are not satisfied, that means you don't have 2/3 of the cortical circumference intact or more than 5 millimeters of subchondral bone, then you would need to fill in that defect. How do you decide? If the patient is more than 50 years old, we generally use bone cement. If the patient is less than 50 years old with more than 5 millimeters of subchondral bone left intact, we would prefer a more biologic material like bone, either autograft or allograft. So you try and fill the entire cavity with bone. If bone is not enough, then you may use cement. If you have less than 5 millimeters of subchondral bone left behind, then we would definitely prefer to recreate an area of subchondral bone with bone graft, and the rest of the cavity can either be used or packed in with allograft or bone cement, depending on the situation that you work in. But under the area of the subchondral bone, we would definitely prefer to create a layer of graft. This is known as the sandwich technique, which you can see demonstrated here. A layer of bone laid below the subchondral bone, then a layer of gel foam to protect that subchondral bone from the hyperthermic effect of cement, which is used to pack the rest of the cavity, because sometimes you may not have enough bone to pack the entire cavity. You can see this demonstrated very elegantly in this X-ray, where you have minimal residual subchondral bone. Then you have used bone graft as a layer over there, gel foam, which is a radiolucent line seen in the radiograph, and cement below, thus allowing or enabling restoration of bone stock. The advantage of this technique is that, God forbid, if you get a recurrence, you get a second bite of the cherry, because the bone that is there below the subchondral area allows you to curette again. If you had packed the entire cavity with cement, sometimes that's not possible, and a resection becomes the only option when you have to treat a recurrence. Some of these lesions may be skeletally unstable at the end of your curettage, and you would have to use your judgment whether to use internal fixation or not to stabilize this construct. A critical point to remember is that when you're harvesting bone graft, please see that you use a separate trolley, a separate set of instruments, because otherwise you can lead to cross-contamination at your bone grafting site and land up with a rather embarrassing situation where you have implanted a giant cell tumor in an area where it didn't exist. So this is some basic care that must be taken when you are harvesting a bone graft. There are quite a few questions that arise in the mind of routine orthopedic surgeons when pertaining to giant cell tumors or aggressive bone tumors treated with curettage. The first one is, does subchondral cement increase the incidence of osteoarthritis? And if you look at literature that is published, I think quite universally the answer is a categorical no. Earlier, there were some sort of doubts, some questions, some inhibitions about using cement in subchondral area, but it has been shown that though the radiographs may occasionally demonstrate signs of osteoarthritic change, symptomatically this is not manifest, and subchondral bone cement does not increase the incidence of osteoarthritis. Second question is, does using cement decrease local recurrence? Earlier, we had thought that it didn't make a difference based on the filler that you used, but over the last 4 or 5 years, there have been a few articles that have actually shown that the use of cement does decrease the incidence of local recurrence. And as you can see on the graph on the top, curettage alone had a higher chance of local recurrence compared to curettage plus cement. The obvious question you will ask me is, why then was I advocating bone in the younger patients? The answer is, you have to balance the two. If you use cement in younger patients, you may prevent recurrence, but you must remember that this is a benign disease. All these patients will have a normal lifespan, and a certain percentage of them will come up for routine joint replacement at some time in life. As we continue to live longer, we know that arthritis is going to set in, and then you're going to require a routine resurfacing joint replacement, not for disease, but because of age. And that is when the time a problem will come if you have reconstructed the entire defect with cement. You would then need a tumor prosthesis rather than a conventional resurfacing prosthesis. And therefore, in younger patients, we still prefer to use bone so that we can recreate bone stock that if they do require a routine replacement, then we have life a little easier at that time. The next question is, if it is a tumor with a fracture, do you still go ahead and cure it? And I think, again, literature is quite sort of unequivocal on that, that yes, the presence of a fracture does not make a difference. You can safely curate a giant cell tumor with a fracture, and your incidence of local control is about the same as to whether there was a fracture or not. How do you manage a recurrent giant cell tumor? Is that any different from managing a per primum giant cell tumor? No. A recurrent giant cell tumor is managed just like a primary. Just the fact that the tumor has come back doesn't make it biologically more aggressive or malignant. So you evaluate each presentation of a giant cell tumor, whether primary or recurrent, on its own merit, and then decide how to treat it. This is the case of a recurrent giant cell tumor in a young 27-year-old. A patient this young, if we do a replacement now, definitely will come in for quite a few revisions as age progresses. And so we decided to treat this with curettage. Here we used cement and fixation because it was very unstable subchondral bone. And you can see at the end of 5 years, no evidence of disease, and the patient has good function. When do you do an excision rather than a curettage? And for that, the answer is that when you have an expendable bone, like the proximal fibula, the distal ulna, then a resection is preferable to a curettage. In the other bones, you would go back to the question we asked right in the beginning, that is there going to be adequate cortical bone left for you at the end of a curettage? When the answer was yes, you did a curettage. If the answer is no, then you proceed with an excision. A case like this, a giant cell tumor of the distal femur, which is recurrent with that sort of bone quality, you are not going to be able to retain stability when you do a curettage. And these are the cases where you will do a resection and replace it with a prosthesis. When you do a resection, you have various options for reconstruction. You can use prosthesis, allograft prosthesis, composites. You can use bone grafts, either autografts or allografts. You can do bone distraction and osteochondral allografts. I've put those in a different color because experience with them is relatively limited and they haven't really shown to have consistent results. This is a case in point, a giant cell tumor of the distal tibia, which we thought was better treated by excision rather than curettage. We excised it. All that we did was transpose the fibula medially along with its soft tissue attachment, do an arthrodesis of the ankle. You can see how well this lady is functioning. So this is another option where you're doing an arthrodesis that you use adjoining bone. One of the biggest questions that is being asked nowadays in giant cell tumor is, what is the role of Denosumab? What is Denosumab? Denosumab is a monoclonal antibody. And how does it work? Now, the rank ligand is a mediator of bone destruction in giant cell tumor and acts by activating the osteoclast to resorb bone. Denosumab binds with the rank ligand and therefore inhibits osteoclast activation. This was supposed to be the new magic drug that would solve all our problems with giant cell tumor, but that has not been really true as we have gained more experience with it. And the questions that we are usually asked are, is Denosumab to be used for all cases? If not, which cases? How much Denosumab do you give? How long do you give it? Is it a substitute for surgery? So let's try and look at what the answers are. We've had a fair share of experience with Denosumab, and earlier this year in the British Bone and Joint Journal, we published our results with the use of Denosumab and what we had learned from it. So again, you need to ask the right questions. Can Denosumab help reduce the morbidity of surgery or facilitate the ease of the planned procedure? Only if the answer is yes, then you use Denosumab. For example, in a case like this, Denosumab really offers no advantage. This is something that can be treated very easily by curettage upfront, and that's how we would treat it. But in a case like this, which, if it when presents to us, we are most likely to resect rather than do a curettage, maybe Denosumab can help. And this is where we gave Denosumab, which helped form bone, and therefore we were able to do an intralesional curettage rather than a resection, which we would have done upfront. A case like this in the proximal humerus, where we know that if we do resection, function is relatively poorer than if we can actually retain that bone after a curettage. But curettage in this larger lesion may not be very easy. And this is where denosumab can help by creating a nice shell or a scaffold against which you can do a curettage, thereby giving you a better chance at clearing disease. And again, this is where we use denosumab, did a curettage, and filled it with bone graft. Another option is a case like this in the proximal radius. Yes, this is going to require a resection. But if you do a resection here, your chance of injuring the posterior introitious nerve is quite high. And in such cases, we would give denosumab to help that lesion ossify so that we can do a surgery, albeit a resection, much safer and preserve the nerve. And that's how this case was treated. You can see a resection with the nerve intact. Therefore, the current indications for denosumab is that it must be used judiciously, not in all cases, but only in the cases where you feel you can reduce the morbidity or facilitate surgery. For example, in helping convert a resection to a curettage, to facilitate curettage, or to facilitate resection, as in the examples that I have shown. How much denosumab do you give? Most of us still use it like how it was advocated in the initial trial study, where you give it subcutaneously in 120 milligram doses given per upfront and on day 8, 15, and every 4 weeks after the first dose. That means day 0, day 8, day 15, day 28, and then at 4 weekly intervals. You can see here again at presentation, the X-ray after 8 weeks of denosumab and the X-ray after 12 weeks of denosumab. How much denosumab do you give? This is a critical question because once you give denosumab, the tumor becomes very fibrous and gritty and your curettage becomes more difficult. You need to do a much more aggressive curettage and there is a danger that tumor cells may remain in the newly formed bone and therefore you may have higher recurrence rates. This is the same case that I showed you earlier, where we converted a resection to a curettage. But on follow-up, you can see the patient developed a recurrence and we had to finally ultimately do a resection. And this happened because our curettage was inadequate because there could have been microscopic disease left behind in that shell of bone. And therefore, now we have learned that the earlier you do a curettage, or the earlier you do surgery after denosumab, the better it is. And the ideal period is roughly about 3 months, which is the right balance between a cortical scaffold or shell being formed, which will help you do surgery, yet not be that firm or thick that you can't address the disease completely. There is no clarity whether denosumab should be continued after surgery because adding denosumab after surgery doesn't really seem to reduce the risk of local recurrence. So data regarding long-term use and safety is also limited. Therefore, we at the Tata Memorial Hospital don't give any denosumab postoperatively. Can denosumab avoid surgery? No. Denosumab is an addition to surgery. This is a case in point. You can see a patient in the pelvis with a giant cell tumor presented to us. We gave the patient denosumab, ossified beautifully, making curettage easier. But because the pain subsided, the patient decided not to undergo surgery, went away and presented to us a few months again later with recurrence of disease like this. So it is well documented that once denosumab is stopped, recurrence can come back. And therefore, people, given if are treating with denosumab definitively, would need to give long-term, lifelong denosumab, which has its own disadvantages. Where are the cases where denosumab can help avoid surgery? Cases like this, sacral giant cell tumors, where earlier we used to treat with angioembolization because surgery had the risk of damaging sacral nerve roots and the patient losing bladder bowel. Today, we combine angioembolization with denosumab. That means denosumab is not used alone, but as an adjunct along with angioembolization to help treat these cases. You can see in 2014, that was the presentation with denosumab and angioembolization, the disease has remained stable Denosumab is again given only for 6 doses and a few sittings of angioembolization. This is not lifelong denosumab. So these are the sort of cases where we may use denosumab as an adjunct to avoid surgery. So what are the lessons that we have learned with our use of neoadjuvant denosumab? One, it is not a substitute for surgery. It is used judiciously in the neoadjuvant setting, not for every case. And currently, the role is to help convert resection to curettage or to facilitate curettage or resection. Surgery is easier if you operate as early as feasible, because otherwise curettage can be more difficult. So you will realize that these lesions, though benign, do require a bit of thought to treat them. The main aim is to maximize functional preservation while minimizing the chance of surgery. So thanks to this initiative from BOS, you now, I think, have learned about how to get it right from the A to Z for benign bone tumors. A is from the approach to Z, where both you and your patient can hopefully rest peacefully once you've treated this correctly. Thank you once again for this patient listening. Thank you, Swapnil and BOS.
Thank you very much, sir. That was indeed a wonderful presentation, made very, very simplistic for all of us to understand. And I would request the viewers of this webinar, if they have any questions, kindly post them in the comment section, and we'll try and put it to the specialist and he will answer them. Thank you very much, sir, for sparing time for the Bombay Orthopedic Society. And I, on behalf of the society, thank you for this wonderful webinar and for helping us understand and making simple these benign bone tumors and their management protocols. Thank you very much, sir.
Thank you, Swapnil. The pleasure was mine.